our course today. I'd like to prefer to start first with acid-base disturbances and interpretation of blood gas, as it's a simple presentation warming up of our course today. The goal of this presentation today is to know the common acid-base disturbances and how to interpret blood gases and how to intervene accordingly, because this is one of the most common topics you will see not only in ICU, even in wards or in ER. First, we have to know that we have different ways to take the samples for blood gas. We have the arterial, venous, or capillary blood gases. Every place is familiar with one way of sampling. Here, for example, in ICU, I'm preferring arterial and the capillary. You will see in the wards or in ER, they prefer to take venous samples. For arterial sampling, it's taken by arterial stab, or if you have arterial catheter in place. This is what you see most commonly in ICU patients who are severely or critically ill or ventilator or in shock. So they will have arterial lines, so you can take samples more easier. Capillary sample, it's much preferable in pediatric and neonatal patients because it is less invasive than arterial or venous, and you will need only minimal sample for blood gas, and it's mostly accurate like arterial blood gas. The venous route, you can take by also venous stab, or if you have venous line in place. But it is less invasive compared to arterial, but it is also less accurate. The next table just shows the different values according to the sample, either arterial or venous or capillary. You can see arterial and the capillary almost equal in values regarding the pH, PCO2, PO2, and bicarb. Venous is different from both regarding all the parameters. Always take care of your blood gas and values by which measure. Some places are preferred to take the PCO2 and PO2 by kilopascal, like here in Gulf or UK or some USA. I know in Egypt or some other countries, they prefer millimercury in measurements. So always take care of this during the interpretation of your blood gas. What are the defense mechanisms in our body to keep our blood gases within normal, to keep our pH in normal? We have cellular mechanism inside the cells and the extracellular mechanism. Usually the intracellular levels for keeping pH within normal is faster, work within minutes or few hours. This buffers includes many proteins in the body, hemoglobin and phosphate. The extracellular buffers, we all familiar with them, most of them are lungs and kidneys. We know lungs will work more faster than kidneys within first 12 or 24 hours to adjust blood PCO2 by changing the ventilation effort, either by over or under ventilating the patient to wash out or retain CO2. Kidneys will work slower, will take days to adjust by excreting hydrogen or reabsorption of bicarb and base. But always remember, our body never overcorrects itself. So overcorrection is always iatrogenic, always done by us. Here we'll discuss the most common acid-base disorders we see in your patient. There are simple disorders which will include only one disorder, either respiratory or metabolic, either acidosis or alkalosis. Sometimes we'll face mixed disorders, could be mixed acidosis, both metabolic and respiratory, and also mixed alkalosis, metabolic and respiratory as well. The most common disorder we'll see is respiratory acidosis. As you see on the screen, you will expect your pH will be reduced below 730, and your PCO2 will be high, and your bicarb still will be normal in the early stage before the body starts to compensate. The most common causes of respiratory acidosis, as we know, is always CO2 retention due to respiratory causes, either pneumonia, severe asthma, pneumothorax, or even muscle disorders, or due to respiratory depression, secondary CNS depression by CNS insult, infection, or drugs. As we mentioned before, our bodies will try to compensate through the kidneys by training bicarb and excreting hydrogen excretion. How to manage respiratory acidosis patient? Usually this patient will need respiratory support and the treatment of the initial cause, if there is infection or pneumonia or whatever, and mostly this patient will be admitted in ICU or high dependency unit. The second disorder we could see, but you will not see much in the ward or ER, you will see more in the ICU, the respiratory alkalosis. From the name, we can expect pH will be high, more than 745, your PCO2 will reduce, and bicarb is normal. The most common causes, as we mentioned, you see in PICU by hyperventilation. It's usually secondary to mechanical ventilation. You can see other causes, which is rare to see in pediatrics, liver cell failure or salicylate poisoning. As we expect, our body will compensate by decreasing hydrogen excretion and excreting more bicarb to correct the alkalosis. Metabolic acidosis is the most common disorder you will ever see in pediatrics, in ER, in ward, or even ICU. pH will be low, your bicarb also will be low, PCO2 will be normal. But if body tries to compensate, you will find kidneys try to compensate by increasing the hydrogen ion excretion and losing and retaining bicarb. Lungs will try to compensate by hyperventilation to wash out CO2 if the patient is not ventilated or in ICU. What are the most common causes of metabolic acidosis we can see? The most common causes you will see in ICU is lactic acidosis, which is usually secondary to septic shock, or ketoacidosis, like diabetic ketoacidosis, acute renal failure due to loss of bicarb, or excessive production of acids. One of some common causes that many of us couldn't pay attention to it is use of isotonic saline, large doses of isotonic saline. You will have hypercholoremic metabolic acidosis. The other causes of metabolic acidosis, as we know, related to anion gap. We have anion gap metabolic acidosis and the normal anion gap metabolic acidosis. And we all know the anion gap is the difference between the positive cations and negative anions, and it's normal from 8 to 16 milliequivalent per liter. Here's the next picture summarized the high anion gap and normal anion gap metabolic acidosis. Is my voice is clear? I think some of our audience cannot.
No, your voice is clear, Dr. Rehab. Go ahead.
Okay, okay. So how to treat metabolic acidosis? Usually the treatment depends on first treatment of the cause. This is crucial in treatment of metabolic acidosis. Always treat the cause. Don't rush to correct the acidosis by giving bicarb. This is not routine in management of metabolic acidosis. Correction with bicarb has limited indication, limited only to severe acidosis, which is intractable, could not be corrected even with all measurement to correct treating the cause, giving the fluids, or giving inotropes, correction of the shock. If you have severe acidosis, your pH is below 7, your bicarb is below 15, that time we can give bicarb. We have this equation to calculate the bicarb deficit that you can give to correct your bicarb to reach only to 15 milliequivalent per liter. I don't want to target more than 15. According to this equation, the 15 minus the measurable bicarb you have, multiplied by 0.6, multiplied by body weight, this in milliequivalent, and you can give it all correction over 8 hours, for example, or 6 to 8 hours. Then you can assess your patient according after that. The fourth disorder is metabolic alkalosis. Here our pH will be more than 745, bicarb also will be high, and PCO2 will be normal. You can expect here our lungs will try to compensate by hypoventilating to retain more CO2. Kidneys also try to compensate by retaining hydrogen ions and excreting more bicarb. What do you think? What is the most common cause of metabolic alkalosis you can see in patient who is in ICU? Any idea?
So, Dr. Rehab, due to the high number, we will get the answers in the chat. Can you see the chat, or shall I read them for you?
Yes, I can see.
Okay, so to answer Dr. Rehab and our other presenters' questions, you can write them in the chat so they can see your answers. So Dr. Muhammad Adil is telling you sections. You can read these, right?
Yes, Dr. Muhammad Abdelalis, he said laxative, Lasix. Yes, exactly. This is one of the most common causes of metabolic alkalosis in ICU. Diuretics, use of diuretics. As you know, One of the strategies of management of ARDS, for example, is to keep their lungs dry and use diuretics. And one of the side effects of using diuretics is to have metabolic alkalosis. Also, if you are using bicarb infusions, you can see metabolic alkalosis, but usually this shouldn't happen. This means we overused bicarb to have metabolic alkalosis. But there is other causes of metabolic alkalosis. As you know, the common causes of metabolic alkalosis that you can see in pediatrics like Barter's or pseudo-Barter syndromes. How to treat metabolic alkalosis usually depend on treatment of the cause, and always be sure that patient has adequate extracellular fluid volume. This table summarizes what we have mentioned before about the 4 disorder, but this uncompensated disorder, you can see still the body didn't work to compensate and summarize the common causes of each disorder. How to interpret the blood gas? If I have an ABG or blood gas paper, how to interpret the blood gas? I have to have on my mind a skeleton to always work through during manipulating patient who have disordered blood gases, including deciding first, is it acidosis or alkalosis? Is it respiratory or metabolic? Is it compensated or still not yet compensated? How is the oxygenation status? Is it hypoxic? Is it venous? Is it capillary? Is it simple disorder or is it mixed? Is it acute or chronic, or is this a laboratory error? That means that is not correlated clinically with your patient. With this approach, put it in your mind, try to manipulate any blood gas you will face. We'll use this approach in manipulating the following scenarios. So I will wait your answer on chat, as Dr. Ahmed mentioned. We'll start. What do you think about this blood gas? Dr. Sahar, she cannot hear the voice, but she can see the
It's usually screen. A problem from people's side. Our attention.
Maybe you mute my voice, Dr. Sahar. Check your mic, your
okay.
Voice. Maybe you muted me.
We'll move to the question, Dr. Rehab. Go ahead.
Yeah. So, what do you think about this blood gas? Is it exactly, Dr. Aus? Yes, this is respiratory acidosis. You can see your pH is low, it's 732, and PCO2 is high. But according to our approach we mentioned in the previous slide, we can say, is it acute or chronic? Is it compensated or not? Yes. Yes, we can say it's partially compensated. If it is venous, we can say it's compensated because your PCO2 high and see your bicarb also high, it's 31.6. And we can see from this, because the high bicarb, it is chronic respiratory acidosis. Yes, exactly. What do you think about this blood gas? Yes, here your pH. Exactly. We have metabolic acidosis, as Dr. Aus mentioned. Your pH is very low, it's 7. Your PCO2, we can say it is within normal, but your bicarb is very low. What do you think, Dr. Aus? What is the cause of this acidosis? Do you have any finding in this blood gas explains this acidosis? Yes, we have lactic acidosis. Your lactate is high, is 11. So this is lactic acidosis, could be septic shock. So we'll go to the next one. Yes, what do you think about this blood gas? You know, in last blood gas, blood sugar was around 7.8. We cannot say this is hyperglycemic. It's only 7.8. For this blood gas, what do you think? Your pH is 6.8, your PCO2 is 8.9, and bicarb is 1.6. What do you think? If you remember, in the table of values, we said always take care of the values and the measures used in here, millimercury, your PCO2 and your PO2 by millimercury or by kilopascal. But don't be confused by PCO2. We have severe acidosis. First, this is severe acidosis. We cannot say it's alkalosis. This is severe. But to determine is it acidotic or is it respiratory or metabolic, we have to look for PCO2 and bicarb. Your PCO2 is low, it's 8.9 by millimercury. It is not kilopascal, so pay attention for this. It is very low, and your bicarb is severely low, it's 1.6. So we can see this is severe metabolic acidosis. If I give you another idea about this patient, he has blood sugar is 27 and his blood ketones is 7 millimole. What do you think is the cause of this profound acidosis? DKA, exactly. It is diabetic ketoacidosis. Great. Here we have this scenario. We have this baby who is 6 months old now. He was born premature, 30 weeks, complaining of cough, mild respiratory distress, and saturation in room air is 96. And this is his ABG now. What do you think about this blood gas? Yeah, what's your comment in this blood gas? Your pH is 740, your PCO2, and your bicarb and the other parameters? Yes, exactly. It is normal blood gas. Next day, this patient presented with severe respiratory distress. Respiratory rate increased to 68, saturation dropped in room 8 to 89, and his X-ray shows picture of respiratory pneumonia. When we repeated ABG, now we have this ABG. What do you think what happened? Yes, for this blood gas now. Yes, we have respiratory acidosis. You can see pH is severely low, 6.9, and your PCO2 is very high, and still your bicarb almost within normal. So what do you think, this severe respiratory acidosis, what do you think we have to do with this patient? As we mentioned in management of respiratory acidosis, he needs respiratory, yes, exactly, he needs urgent respiratory support. He was admitted to ICU, intubated, and ventilated. On the ventilator, he developed poor perfusion, mottled skin, and his lactate is 5 now, and his new blood gas is like this. What do you think about this blood gas? This blood gas in ventilator, and this is now blood gas. Yes, this child has developed sepsis. You have lactate increasing, and he has poor perfusion, he has mottled skin, and you have metabolic acidosis in the blood gas. So this child have sepsis now. Next day, this child needed more ventilator parameters and still desaturating, and the new X-ray shows picture of ARDS, and we started him on diuretics, as you mentioned, the case for the case of ARDS, and now this is his last blood gas. What do you think about the new blood gas? What is the code? Yes, now we have metabolic alkalosis. Yes, due to diuretics, exactly. You can see your bicarb now is 32.9, which is high. Your PCO2 is, yeah, almost we can say it's compensated. Your pH alkalotic because of use of diuretics. The normal lactate level, as one of our doctors asked, the level is up to 1.5 to 2. This is the maximum level of ketone of lactate we can accept. More than 2, it is abnormal. Then after 4 weeks in the ICU, after management, this child started to improve and was extubated and discharged to the ward with this blood gas. What do you think about this blood gas? Yes, now this blood gas pH is normal, but your PCO2 is slightly high. Your bicarb also is high. So what's going on in this one? Yes, we have high, yeah, this is chronic and it's compensated. You have high bicarb, which compensates your high PCO2 to keep your pH normal. But this is compensated blood gas due to increased bicarb. This is secondary to the chronic changes may happen to the lung because of the stormy course in PICU and the ARDS, and this child needs strict follow-up later on. Yes, it's compensated. So I finished all scenarios now. This is almost the final slide. Just we have to know from this slide that blood gas disturbances should be treated promptly and try to find the cause, and always concentrate about the cause because it's a crucial item for management. The blood gas abnormality should be analyzed together with the clinical scenario of the patient. Always treat both the patient with blood gas and always correlate between the blood gas and your patient. And the blood gas values should be looked for, as we mentioned before. And not all bad blood gases or acidotic blood gases integrate PICU admission except if the patient in shock. And usually keep your patient in normal fluid, electrolyte status, blood gases, because they are the cornerstone or backbone of pediatric intensive care for your patient. Thank you. I finished my presentation if you have any more questions.